Well, hello everyone, and welcome to the Learning Lab event addressing food insecurity in Washington State. My name is Emily Noodleman, and I'm the Transformation and Community Partnership Manager at the Foundation for Healthcare Quality. In my role, I primarily support the Bree Collaborative program in the implementation of the reports into practice, and also support the Foundation's health equity work. We are all very excited to have each of you join us today, along with our speakers, as we engage together in this event and explore how the Bree reports and Foundation's social need and health equity reports can be implemented into the healthcare ecosystem to ensure equity is centered within our implementation efforts. The agenda for today's event is to provide a short introduction to the Bree Collaborative. Then we will have the opportunity to hear from our speakers. We'll have a presentation from our panelist, followed by a discussion. During that discussion, you can pose any questions you have for our speakers, either by coming off mute or in the chat. And then we'll transition into a small group discussion and wrap up the event. Again, during the event, please ensure your first and last name and any credentials you have appear in your username or Zoom. This is for attendance purposes and part of that CME and CPE accreditation forms. Please ensure that you are on mute throughout this process. And also the recording will be accessible for the presentation after the meeting on our website. As we begin, we do just have a couple items we want to review with you. The Learning Lab event has been approved by WSBA for individuals to obtain CME credits. The CME credits are available to claim for individuals who are attending the live event only. Unfortunately, we're unable to provide CME credits for individuals who watch the recording. To receive the CME credits, please complete the post-webinar survey, which will be linked at the end of this event. You will be able to access that survey, and through that survey, once you hit submit, you will see this screen. When you see this screen, you will see if you'd like to claim the CME credit, that you need to submit an additional form, and you can access that form by clicking the Here button. That will take you to a CME claim form where you have the opportunity to provide your information, and Bree staff will follow up after this event in a couple weeks with a physical certificate for you all. No one in control of content has indicated any relevant financial relationships with an ACCME defined ineligible company, also known as commercial interest. All clinical content presented will be evidence-based and unbiased. This Learning Lab has also been approved by Washington State Pharmacy Association for pharmacists and techs to attain the CPE credits. Again, these credits are also only available to claim for individuals attending the live event today. We also have no disclosures to share for this event for the CPE portion. And you can claim the CPE credits by completing a different form. It will be a Survey Monkey, and that will also be linked after this event and emailed out. These are our learning objectives for today's event. First, we're going to work to identify how a Bree or Foundation Healthcare Quality Guideline can be implemented into practice. We're going to recognize how social drivers of health can impact a person's overall health status, plan or modify strategies to center health equity into quality improvement initiatives, and engage with peers working throughout the healthcare ecosystem who are in attendance today. We want to provide a brief introduction to the Bree Collaborative. As a brief intro, it was developed in 2011 by Washington state legislation so that public and private healthcare stakeholders would have the opportunity to identify specific ways to improve healthcare quality, outcomes, and affordability in Washington state. These stakeholders are appointed by the governor as the collaborative members and represent public healthcare purchasers for Washington state, private healthcare purchasers, health plans, physicians, and other healthcare providers, hospitals, and quality improvement organizations. Each year, our members identify healthcare services with high variation in the way the care is delivered, that are frequently used but do not lead to better care or patient health, or that have patient safety issues or inequities. Once a topic is identified and chosen as a focus for the next year, the Bree Collaborative forms a work group of subject matter experts to develop the report that provides information and guidelines for actions different audiences can take within the healthcare ecosystem to improve the care for that topic. In 2023, the Bree facilitated a work group on diabetes care and developed a report that was published in January of 2024. In that report, there was a handful of different information on how can we address food insecurity in the state. One was recommending that we screen for food insecurity and other social needs. We also highlighted the importance of partnering with community organizations to increase access for patients to healthy produce, such as fruit and veggie prescription programs or medically tailored meals. You'll hear about a fruit and veggie prescription program today, and also some other opportunities in which we can support people who are experiencing food insecurity within our state. We also at the foundation have a report on addressing social need interventions and how to do that. So we're excited to highlight those for you today. Our speakers for today are Katie Rains, Bryce Montgomery, Lauren Lewicki, Felicidad Smith, and Adele Esslinger. I'll now invite Katie forward to start us off.
Hey, good afternoon, everyone. Thank you so much for joining. It's my pleasure to be with you. Could you take us? There we go. All right, so it's my pleasure to join you today, and thanks for sharing your lunch hour with us to talk about the important issue of hunger in our communities. I hope that while you're off camera, you are not experiencing hunger and enjoying a meal in the middle of your day. For my part of today's Lunch and Learn, I'm hoping to share with you what agriculture has to do with hunger in our state, why food security is a cross-sector issue, what Washington State learned about food security during the COVID-19 pandemic, and what you in your roles as physicians, as medical professionals, and healthcare administrators can do to assist and advocate for your patients who are experiencing hunger. I also will just make a note that in 2008, I had the pleasure of serving as the founding director of the Washington Free Clinic Association, and made the delightful connection that one of the folks on my hiring panel is actually on this call. The part of why I bring that up today is that as I ask you all to view hunger as a cross-sector issue, not agriculture or DSHS or Department of Health problem to solve, but something that we all need to be invested in, I want you to know that I walked through that same door and began working in food systems myself because of the related impacts to community health and well-being. Next slide, please. So, what does hunger have to do with agriculture? I want to just tell you a little bit about the landscape of agriculture in Washington, and I'll keep this part brief. Over 32,000 farms. One thing to note is that that number is actually slowly declining. So I'm going to emphasize today the abundance of agriculture and available food here in Washington. However, it's not like agricultural viability and the ability for ongoing production is something that is still relevant in food security. So as you drive through Washington and then look at these numbers, I think everyone on this call has sufficient evidence that there's lots of food in Washington state. And these numbers also point to the fact that huge is a significant economic driver. But it is worth noting that the majority of those 32,000 farms are small farms, 89% of them. And of all the farms in Washington, 82% of farms have at least one person with off-farm income, one source of off-farm income just to get by. While we have some extraordinarily valuable specialty crops, agricultural viability is a real concern. And even as Washington State looks to adapt and fill some gaps in domestic food production resulting from climate changes, it is not uncommon for farm owners to turn to a food bank in the off-season, and it's even less uncommon for farm workers to need some form of food assistance throughout the season. These farmers and farm workers are your patients too. Next slide, please. So crop production, you're like, what do I care about this? I mean, take a look. I imagine that some of you might be from the Midwest on this call. And I've had the pleasure of driving through Western US a couple of times over the last year, and we certainly have a lot of corn country and a lot of cattle country and a lot of wheat country. And we have all of those things here in Washington, but we also have a very diverse set of nutritious mixed produce. And so none of those individual commodities are bad, but we've got it all. We are among the most diverse producers of foods in the United States. We have over 300 commodities. And that mixed produce is a key to good nutrition. I want to say a little bit about the Farm Bill now, because this will tie back to kind of your role and how you can advocate for your patients. So the first Farm Bill was enacted in 1933. It was a response to the Dust Bowl and the Great Depression. The last Farm Bill, the most recent Farm Bill, was passed in 2018. It contains 12 titles ranging from commodity programs to conservation, but the title that you should all be familiar with if you care about food security in Washington is the nutrition title. 73% of the last Farm Bill, that might have been a typo. I thought it was 76%. I might have miskeyed that. 76% of the last Farm Bill funded essential nutrition programs, including several that you're going to hear about today from both myself and my colleagues. The Farm Bill, if you're not familiar, is a 5-year omnibus bill that's currently operating on a continuing resolution. It was supposed to be passed last year, and we did not get to even a draft in 2023. So it's on continuing resolution through the year while the House and Senate continue to negotiate. The nutrition continues to fund Section 32 surplus purchasing, which favors larger commodities. And historically, the US government has subsidized production of corn, wheat, and soy rather than mixed vegetables, for example. I did not have time in preparation for this, but I think that there are some very interesting correlations in when you see meaningful dietary changes and diet-related chronic disease prevalence increase in the United States, and when some of those commodity subsidies started spiking. So there is a relationship between agriculture and the availability of certain products and how your patients are faring. Next slide, please. So if you all are involved in doing food security screening, then you've already seen these 4 definitions. I'm going to speak more broadly to kind of what is food security when we talk about it here at the Department of Agriculture. It's namely 3 questions: availability, accessibility, and affordability. So availability, is there food? Again, going back to the massive production and diverse production in Washington State, there's plenty of evidence there's food available in Washington State. So is there enough food in a specific geographic area to meet the nutritional requirements of the people who live there? That's the availability part of food security. Accessibility, can the food get to me? Or if I live in a rural or remote part of the state or an urban food desert, or if I don't have a car or am I homebound, can I access food in my kind of local orbit? That notion of meeting people where they are. Can we get food to where folks are actually going in their day-to-day lives? And then finally, affordability. Is the food available at a price I can afford? And there are 2 sides of affordability, of course. Is the cost of the food commensurate with its value? And that's a whole big can of worms around values-based purchasing. And we could compare what the average American spends as a percentage of their income on their food versus other countries around the world. And it points to some of our values. However, the other side of that coin is also, do I have enough money to purchase food that I want and value at a price that's fair to that grower? When we talk about food, the food security safety net in Washington, the reality that food is available and often, but not always accessible. But due to low incomes and wealth disparity, people usually can't afford the food that they value. That's what we're talking about when we focus on food security and this food safety net. Because those factors are not governed by a single institution, addressing food insecurity requires a cross-sector systemic approach. The last thing I'll say about that, and I don't know how often you all look at some of the data about incomes across our state, but so 2022 data, I just did a quick review of the Kaiser Family Foundation, and 49.5% of Washingtonians are at or below 400% of the federal poverty level. And that's $111,000 for a family of 4, pre-tax. So you have one major health event, you have one aging parent that needs to relocate, you have one crisis, and up to half of our state's population could need to turn to some kind of food assistance or food resource to get by and to keep food on the table. Next slide, please. So the food safety net, you get to hear about a number of these programs today, but if a person has low or very low food security, they need as many of these safety net programs as they're eligible for. One is never enough to alleviate hunger on its own for the whole month. These programs, however, are administered by 4 different state agencies, and we all are working with a mix of different federal and state funding and all of the associated rules that come with that and enrollment processes that come with that. It is not streamlined. So if your patients have difficulty navigating that, it's not that we don't care. It's that it's like Plinko on Price is Right. The funding and the rules fell into different cups, and we're all trying to navigate that to create the most access for them as well. And so that's why it's important for institutions like hospitals, federally qualified health centers, and others to play a role in helping folks navigate the available resources, or understanding that folks who have some institutional navigation skill to be able to help folks understand the resources available to them. Before I move on, I'll share one more thing. Please note that both DSHS, the Department of Social and Health Services, and the Department of Agriculture administer food assistance programs. That one yellow highlighted there. They are regularly confused and they're very different, but please don't blame us. We do not make the laws that define our programs and name them. So we do have 2 state food assistance programs. I think I'll be able to make it clear how they're different. Before I move on from this slide, the last thing I'll share is that at the onset of the COVID-19 pandemic, and actually every time there's a risk of a federal shutdown, all of these program leadership get together and connect to discuss how service will be impacted and if there are ways to kind of shift weight within the system or address kind of gaps and needs based on funding changes to one program. During the first 2 years of the COVID crisis, Governor Inslee appointed my director with support from me and one of his key policy staff to lead the food security coordination team. And we were meeting regularly for the first 2 years of COVID. We had legislators who were part of those calls. We had governor's office staff, FEMA representatives, the largest hunger relief NGOs in the state. And when I say legislators, both sides of the aisle, both House and Senate. It was the most comprehensive and coordinated opportunity for folks administering these different programs to see how clearly it really is that net or web, like one set of resources over here can create a reduction in burden over here. It happens almost instantly, but while we have to advocate for our programs separately at the institutional level here, you all as partners in fighting hunger can observe them as a whole safety net that need to be lifted up and kind of boosted together. Next slide, please. So what is food assistance? Let me put a little asterisk in there. What is Department of Agriculture's food assistance? Our food assistance is more or less, we're a grant maker to community-based organizations. We provide state and federal funding as well as food from the federal government. We issue that through a number of different methods, including competitive grant solicitations, a network of lead agencies that are often community action councils or larger hunger relief entities that have more administrative capacity. But we issue funding and food to this network of independently operated, and that's just sort of like, this is not post offices and libraries. Your food banks are your neighbors. It is communities of faith. It is folks who care, trying to make sure that their neighbors have food every night. They are generally nonprofit organizations, so we do not, there's a few caveats, but for our food assistance programs, we support nonprofits and we support tribal organizations and tribes themselves. I have heard questions from folks in this field before of like, well, when there's more need, when we're seeing more folks showing up hungry in our community, how does more funding get released? We don't have any control over that. And that's a really unfortunate reality, is that these programs are not complete funding. On average, the funding and the food that we provide, which is not insignificant, it's still usually only about 10%. In more rural communities, certainly it can be the commodities we provide can be a much larger portion of the food that's available for that community. However, by and large, across the 500 organizations that we support across the state, we're only providing about 10% of the total funding or value of food that they're distributing. And so that's important to note, that means we have compliance requirements, of course, for them, but we don't kind of own, control, direct their operations. Like, we're providing a portion, but your community is really supporting the rest. And then that other part, it is not tied to changes in the rates of food insecurity. So there's no natural mechanism when there are changes that occur, excuse me, here in Washington State, and like in COVID, we had to advocate to the governor's office for special emergency funding. We've had to advocate to the legislature, but there's no kind of switch that flips when there's a spike in hunger for any reason. That means that the state has more resources to issue to address that need. And then finally, in part because the amount of resource we're providing is such a small fraction of the total need, we are not in a position, we've never been asked, directed, or authorized to lead or coordinate this independent network. So we are here to provide resources and kind of use those as carrots to incentivize cooperative behaviors and creating more access, overcoming barriers, and certainly enforcing non-discrimination laws. The last thing I'll say about it, because I made a point of talking about some of the commodity programs and subsidies in the Farm Bill, But one of the really extraordinary things that has happened during COVID-19, as our agency budget doubled in just a year, and we've spent over $250 million, having never purchased any food at the State Department of Agriculture before April of 2020. We've spent $250 million putting our pro-producer anti-hunger ethic to work, buying food from farms and or supporting hunger relief organizations to buy food from farms that is culturally responsive, that is dignity food, that is tied to what people want and value. Because it's never a good sign for any kind of resource to just go to waste, even if we think it's the resource someone might want or need. We really have supported mechanisms for self-directed purchasing from those local organizations. Next slide, please. So in 2019, a couple of fun facts. That was the first year actually that we saw the number of people seeking food assistance go down from pre-recession. So it was 3 years after the 2008 peak recession. It was 2011 before we saw the highest number of people go to a food bank. And the theory is that by that time, whatever relief resources were available were gone. But also kind of personal safety nets and other assets were depleted. If you had stuff to sell to get by, most of that was complete by 2011, and folks had the greatest need with the fewest government relief available. So 2019, we finally hit a new low, or went back to pre-recession levels, and then it skyrocketed in 2020. And at its peak, we believe 1 in 3 Washingtonians was at risk of hunger or experiencing hunger. Then fast forward to 2023, we saw that was the first time that the number of food bank visits exceeded 10 million in our state and was actually nearly 11 million. The thing that I will point to is that we're going to talk about the need for more resources across the nutrition safety net overall. But in 2019, the state investment was 78 cents per visit. 2023, it was $4.19 per visit. In this upcoming legislative session, if the state legislature, not the federal farm bill, but if the state legislature doesn't continue any of that funding, the state investment in 2025 will go down below 78 cents per visit. So that's not insignificant and something we are certainly advocating for and have been, have been pleased to have support from the governor's office on, excuse me. Next slide, please. I'm not going to talk in detail about this. I think these are things that are quite obvious to all of you, but it's my reminder, like, this is why it matters to everyone. And I hope that when you leave today, you're not just talking to your medical professional colleagues, but everyone you know. We know hunger is a well-documented health disparity. We know hunger widens the educational achievement gap. We know that it has long-term costs and future health outcomes and impacted lifetime earnings. We know all of that, and we know that it affects marginalized groups at much higher rates. So if we know all of that, what can we do? Next slide, I'm wrapping it up, I promise. So direct assistance. You can help your patients navigate the available resources. That largely means developing institutional partnerships with the local hunger relief organizations in your area, as well as local entities that enroll folks for some of these other federal and state programs, as well as schools. You can also talk to your accountable community of health about options to support Medicaid transformation waivers to spend on food assistance programs. Those are some of the direct things that you can do. My colleagues today will certainly share more. The other things that you can do as you think about that big picture and leveraging some of the clout that you have in our communities is consider your role for organizing and advocating for that farm bill. The nutrition title and our next speaker will speak to SNAP benefits, and that's the largest single item in that nutrition title, and it makes a huge difference to a ton of Washingtonians. You can organize and advocate both for your hospitals and health systems with our state legislature and also for your patients and their food assistance needs. And then you can connect with county health and human service departments and find out what resources they have available, because they frequently do have funding to issue, and hearing more from more stakeholders can help them reprioritize if they're not spending it on food assistance currently. Thank you so much for your time, and giving me
Thank you so much, Katie, and thanks for the overview for the state and also the Department of Agriculture. In her presentation, you heard her talk about food assistance and how that's also something that goes on in DSHS. So we'll invite Bryce Montgomery to come forward to talk a little bit more about DSHS.
Good afternoon. As noted, my name is Bryce Montgomery, Interim Director of the Community Services Division, which is part of the Department of Social and Health Services. So I'm here to talk about basic food in Washington State. And basic food serves about 500,000 households, representing about 900,000 people each month in Washington. If you would hit the slide. Thank you. The Supplemental Nutrition Assistance Program, or SNAP, is the federally funded program that serves U.S. citizens and federally qualified, legally admitted immigrants. We also have a state-funded program called the Food Assistance Program, or FAP, F-A-P, to fill gaps when legally admitted immigrants are in a waiting period for federal eligibility. If you click, I think you can get the FAP. There you go. Nationally, the program is called SNAP, so you may hear SNAP used in reference to the federal program and FAP when referring to the state-funded benefits. And with the exceptions of the immigration distinction and the funding status, state versus federal, SNAP and the Food Assistance Program are mirrors of each other, so eligibility criteria is the same for each. We follow regulations from the Farm Bill that are further detailed in Code of Regulations of CFRs. It's a highly regulated program, but the goals are to provide supplemental funding so that households can purchase healthy foods and to help individuals move towards self-sufficiency. Next slide, please. Washington's basic food program has several components. The first we'll talk about is basic food outreach, which works through contractors throughout the state to increase knowledge of the program and to connect people who are potentially eligible with DSHS to apply for benefits. Secondly, and you can just click, I think, to get there it is, SNAP Education or SNAP Ed focuses on nutrition, stretching food dollars, living physically active lifestyles, and engaging partners to build healthier communities. This helps to ensure that the healthy choice is the easiest choice to make, where people live, work, play, shop, eat, and learn. We manage this program through contractors in local areas with specific and measurable goals. And one more click, I think. We also partner with the Department of Health to provide incentives like Market Match and SNAP Produce Match to give a matching rebate for future food purchases when food assistance is used to buy fruit and veggies at participating farmers markets and some grocery stores. And I think you'll hear about that a little bit more as we progress through the program. Next slide, please. So for the most part, people think when they think food assistance, they think that this is the part where people usually focus on when we're talking about basic food. In CSD, our eligibility staff interview applicants and review active cases to determine program eligibility. People can apply for food assistance in person, online, over the phone, by mail, or by fax. And then occasionally we also have trucks that go out to people's homes and areas of business and community partners. We're also able to conduct interviews in person by phone, and we always provide an interpreter and translated communication to clients that need access to our services in other languages. Most cases are certified for 12 months of benefits with a short review period due in the middle of the certification period to confirm continued eligibility. As part of basic food, and I think you can click again, we have some specialized services to increase program access for elderly or disabled individuals. The Elderly Simplified Application Project, or ESAP, is for households where members are elderly disabled and no one has any earned income. The certification period for this program is 36 months, and once certified, we can waive the certification interview as long as we can verify the household's circumstances are the same. Approximately 174,000 participants are served under ESAP. And one more click, I think. Nope, go back one, sorry. And the Washington Combined Application Project, or WashCap, allows people who are elderly or disabled to apply for both SSI and basic food in a single application at Social Security. Social Security verifies their circumstances and sends the information to us to open benefits when SSI is approved. People who apply for the regular application process will have their cases converted to WashCap if they qualify for the program, which, like ESAP, provides a 3-year certification instead of requiring an annual review. WashCap serves approximately 73,000 individuals each month. And a click of the slide, please. Oh. We also have a basic food component and training program, or BFET, that links recipients with community-based organizations to assist with building job skills and finding work. BFET partners with many organizations to help reduce barriers to work and provide some support services such as transportation and childcare as people prepare to get and keep sustained employment. A great program. BFET is excellent. Basic Food helps transform lives. We provide outreach to help people learn about the program and apply. We determine eligibility, issue benefits, and help people maintain benefits. We support active households with education on nutrition and healthy lifestyles, and we assist clients in gaining self-sufficiency through employment and training programs. One more click, please. So you can access us in any number of ways. The first way would be our customer service contact center, and the number is there on the screen. We also have about 50 local community services offices throughout the state. And there's if you click on that link, if you're able to, we have a finder. You can search by zip code or a local town, and you should be able to find the closest community service office to you. And the last would be online at washingtonconnection.org. Our local community service offices and customer service contact center are available from 8 a.m. to 5 p.m. Monday through Friday, and interview hours are from 8 to 2 Monday through Friday. So customers checking in before 2 o'clock will be served the same day, even if they continue to wait to be seen after 2 p.m. At a CSO or contact center, customers can apply for benefits, complete an eligibility review or mid-certification review, and complete required interviews. They can report changes to any benefit program, including SNAP, and request replacement EBT cards, reach a case manager or case worker, ask questions about their case, and all languages are supported at either the CSOs or the contact center. Contact Center also offers access to a self-service option. Customers can check their benefit type, benefit status, and benefit amount, and upcoming appointments, and any messages left by a caseworker. Customers can also hear their EBT balance and verify their document status, get answers to frequently asked questions, manage their EBT PIN information, and be transferred to a live agent. And online services are available 24 hours a day, 7 days a week through our online portal, which is Washington Connection. And there you can complete an application for basic food, cash, medical, or childcare, or all of the above. Complete an eligibility review or mid-certification review form, complete a change of circumstance form, create and access their client benefit account, which provides information that allows households to track benefit information. With the client benefit account, customers are able to see access to their pre-filled certification forms, client benefit amounts for up to 12 historical months, check for status of pending applications, reviews and documents, see child care provider and copay amounts, and be reminded of certification and dates. There are other programs that you can find online, a service page, which allows customers to search a list of other agencies and programs that offer customer services, and a public access directory that provides a list of community organizations that provide assistance used during the benefit portal. I think that's what I have. Thank you very much.
Thank you so much, Bryce. We really appreciate that. I'll now invite Lauren and Felicidad to come forward to talk more about DOH and the work that they're leading there.
Great. Thank you so much, Emily. So hi, everyone. I'm so happy to be here today. I see some familiar names on the call. So for some of you, this might be a little bit of review, but hopefully we can give you a lot of new information. So my name is Lauren Lubowicki, and I am the Retail and Healthcare Specialist with the Fruit and Vegetable Incentives Program at the Department of Health. So all that means is I work with our grocery store partners and our healthcare partners to help remove barriers for food insecure households to buy fruits and veggies. And before we continue, I will let my co-presenter introduce herself.
Yeah, hi everybody. I'm Felicie Dodd, and I actually currently work alongside Emily here at the Foundation for Healthcare Quality as the Communication Resolution Program Manager. But when I was a graduate student last year at UW, I had the wonderful opportunity to work alongside Lauren as I completed my Master Public Health capstone project with the DOH's Fruit and Vegetable Prescription Program. So I'm really excited to be here and talk about FVRx and a little bit about what I learned during my capstone project. Well, back to you, Lauren.
Great, thank you so much. All right, so we're gonna make you think for a little bit before we dive in here. And really, this is really just to kind of set the stage for the why behind this work, because we're here talking about food insecurity. So why are we talking about a program that is specifically about fruits and veggies? So I want you to guess. No Googling the answer, but I want you to guess what percentage of adults in the US meet the recommended daily intake for fruits and veggies. You can just type it in the chat so we can all see it. What percentage? We've got, well, these are flying in. Okay, 20, 10, 30, 10, 10, 30, 15, 10. So clearly some of you are deep into this work. Well, we got a 5. And again, it depends on what source you're looking at, but the data from the CDC in 2019 shows that Katie, good call. Prices, it's not Price is Right rules, but CDC data shows that only 10% of adults are meeting the recommended daily intake for fruits and veggies or for vegetables, and 12% for fruit. So again, that's regardless of income level. So if we then take a step back and look at how that changes based on income, only 6.8% of low-income adults are actually meeting those recommendations. So this maybe isn't particularly shocking that fruit and veggie consumption goes down based on income. One of the reasons being, when money's tight, your priority might actually be getting the highest number of calories per dollar as opposed to really looking at nutrition. In our next slide illustrates this scenario. So this photo was shared from one of our fruit and veggie prescription program participants. And you can see they circled that bag of cherries there. And what they pointed out is that bag of cherries cost the same as those 3 frozen pizzas. So without participating in our fruit and veggie incentive programs, she basically said, I wouldn't have purchased any of this fruit. So, not just the cherries, but the cherries, the bananas, the canned fruits. So this is really the why of why we do this work. It exists to help make fruits and veggies the easy and affordable choice for food insecure shoppers, because that has positive ripple effects on their health, on their well-being, on chronic disease status. So thank you for playing along in our little game. And I will give just a brief overview of our programming and how we do that. So how do we do that? How do we make fruits and veggies the easy and affordable choice? The broad answer to that question is through partnerships across the state. We partner with farmers markets, with grocery stores, and then with healthcare systems on each of those 3 programs. Next slide. And our first, our SNAP Match programs, so kind of tried to make it really easy on the screen there. So SNAP Market Match is in farmers markets, SNAP Produce Match is in grocery stores, and Bryce touched on this a little bit. But if you have patients who are either SNAP eligible or already enrolled in SNAP, please let them know about our SNAP Match programs, because then they can stretch their dollars even further. And especially a lot of folks are, it's recommended that they make some dietary changes, and sometimes that's not accessible to them. So this can be one way to stretch those dollars further and get more fruits and veggies. We work with 123 farmers markets across the state, so nearly all SNAP authorized farmers markets, 231 grocery store locations across the state. So we're not in every corner in every community quite yet, but we do have a fairly large footprint. Next slide. So I'll just give a very brief overview of how each of these programs works. I'm not going to get into it in great detail, but you're more than welcome to reach out to me afterwards if you want to talk details. So how this works in farmers markets is a SNAP shopper visits one of our participating locations, and they go to the market info booth and they tell them, I want $25 in SNAP tokens. So their card will get swiped at the info booth. They'll get $25 in tokens that they can use for any SNAP eligible item in the market. And they'll also get $25 in SNAP market match currency that they can use for fruits and veggies. And the limit on that right now is up to $25 per day at each market. And you can see on there, I put a little image of our SNAP currency, usually the market match currency. The SNAP currency is usually little wooden tokens. Next slide, please. Produce Match in grocery stores. So this is the sister program to Market Match. It works a little bit differently. So in grocery stores, it works one of two ways. So a shopper needs to purchase at least $10 in qualifying items, which is fresh, frozen, or canned fruits and veggies without any additives. And then they're either going to get, depending on where they shop, and our website breaks this down, they either get a $10 coupon printed on the bottom of their receipt, or they get an immediate $5 discount off of their $10 purchase. And we don't do that to make things confusing. It's just really based on the capabilities of different point of sale systems in different grocers. Next slide, please. So how do you all fit in with our SNAP Match programs? So I feel like the best way is really just to make patients aware of these programs. Have free printed resources on hand, and I will, once I'm done, I'll drop those links in the chat here. But you could distribute these in a pharmacy window. You can have them in office for providers to distribute, or community health workers, social workers if a patient screens positive for food insecurity. On those web pages, there is a link at the very bottom to order promo materials. They're in multiple languages. It's free. It's shipped to you. Caveat, SNAP Produce Match materials will be up shortly. They're being reprinted. They're not up yet. But that's really the best way is really to get these materials, get them out to patients, make them aware of the program. And next, I will turn it over to Felicidad to share about our fruit and vegetable prescription program.
Thank you, Lauren. Alrighty, so the DOH's third program, again, is the Fruit and Vegetable Prescription Program, aka FVRx, which does not require SNAP enrollment to participate. So this partnership between DOH and healthcare systems, where a healthcare provider screens their patients for enrollment for FVRx. Then eligible participants are those who screen positive for food insecurity and have or are at risk for a diet-related chronic condition. So once the participant is enrolled, they receive $250 worth of fruit and vegetable vouchers, which takes the form of a paper voucher that you can see on screen in the green. So they'd receive these vouchers over the course of 6 months, which equates to about $10 a week. However, the voucher amount does increase based on household size. And then the prescription vouchers are redeemable at any Safeway store in the state. Next slide, please. So FVRx is going to be moving to a card-based system utilizing technology in January of next year, 2025, which would allow for the expansion of FVRx to additional retailers, geographic locations, and allow Healthcare Authority to utilize the system for produce prescription payments with Medicaid funds. So movement to this card-based system will allow for the FVRx program to be expanded to healthcare systems that DOH is currently unable to partner with. And Lauren will talk more about the options you can do to get involved with FVRx shortly. So why is this transition from paper vouchers to a card-based system taking place? So although FVRx has shown to be a great program at increasing the accessibility to fruits and vegetables among critical need populations, there were multiple barriers associated with the use of paper vouchers. Some program participants had reported experiences of stigma and uncomfortable interactions with grocery store staff when trying to use the voucher. And additionally, the paper vouchers are limited to redemption at only Safeway stores, where participants are kind of confined to a limited selection of fruits and vegetables, and may even have to travel far distances to reach their closest Safeway. So by transitioning FVRx to a card-based system, it opens the door to increased locations where participants can shop, including their preferred grocery store or even farmers markets. And it provides participants with a discrete way to participate in this program and claim this benefit. So for my MPH capstone project that I did last year, I conducted semi-structured interviews with the key program stakeholder groups, which included program participants, FVRx clinic partners, potential farmers market partners, and potential retail partners, all to uncover the barriers that could arise from this transition. So some of the major themes that came out from these conversations include reasons why folks are looking forward to this transition, what they foresee some of the barriers are, what they need to fully buy into this transition, and their recommendations for implementation. So from these interviews, I compiled a list of recommendations based on the feedback that these stakeholder groups shared that will help ensure that the transition is made equitably. From these conversations, I heard that folks are very excited for this transition, mostly at the prospect of being able to use FVRx at other retail locations and having more control over how much fruits and vegetables they can purchase during their grocery store visits, as well, for the most part, reducing interactions with some grocery store staff. And then some of the recommendations that emerged from these conversations included ensuring language accessibility on the card's online portal, incorporating multiple methods for participants to check their remaining balances, and to work with partners to develop a communication plan on promoting the program. So overall, folks are very excited for the future of this program, and we are too. Next slide.
Great. Thank you so much, Felicidad. So I'm sure a lot of you on this, there are some of you on this call who participate in this program. If you don't participate in this program, you might be wondering, gosh, how can we offer this? I'm going to go over a few options here. The first option is the lowest barrier, but has a longer wait. And so one way is to apply to participate in our regular program, which is fully funded through DOH. We closed that application cycle in 2023 and won't be opening it again until spring of 2025, but just something to consider and keep in mind that will be opening again. Go ahead and click. There we go. Option 2, which some folks have done if they have existing funding to support an RX program, but they don't want to reinvent the wheel. We've worked with multiple health systems and nonprofits to basically utilize our existing infrastructure between DOH and Safeway to, you'd place an order with Safeway to order these vouchers and then distribute them within your clinic, and then Safeway would bill you directly for whatever is redeemed. And you can get this off the ground pretty quickly if you have existing funding and a Safeway store near you. So I think that is it for our presentation here. Please feel free. I will drop links in the chat to each of our web pages where you can order SNAP match materials. Again, produce match will be up shortly. But I will drop all these in the chat, and please feel free to reach out with any additional questions. And thank you so much.
Thank you so much, Lauren and Felicidad. We'll now invite our final speaker, Adele Esslinger.
Hi there. I hope everyone's doing well. My name is Adele Esslinger, and I work for United General District 304. Which is a long name, and it's the business name for Skagit County Public Hospital District, number 304. So we serve over 2,000 square miles in Skagit County, Washington, a little north, about an hour north of Seattle. And we no longer do the medical clinical services ourselves. Peace Health came in and took over like the medical services in 2014. And so United General District 304 now serves the community in primarily 3 other ways, like maintaining facilities for the hospital and managing resources. We also apply for grants and other funding sources to run like preventative programming and programming for well-being of our community members. And then we occasionally act as a fiscal sponsor for other organizations in our community who need that sort of fiscal structure to manage funding and projects of their own. So today I'm going to walk us through kind of our way in-house, which is an example of one way that you can address food insecurity as a 501c3, or other structures can also, approach addressing food insecurity in this way, which is the intersection of funding, kind of like Lauren and Felicidad were talking about, and chronic diet-related conditions. And so I'll talk about our Skagit fruit and vegetable prescription program and how it functions in our specific context, and hopefully generate some thoughts and brainstorming that could apply to a variety of contexts. You can go ahead and move forward. You can go again. You can go, yeah, thank you. All right, so Skagit Fruit and Vegetable Prescription Program, or Skagit FVRx, is a free year-long healthy eating program that supports individuals in our community with vouchers, which we call FVRx bucks, to buy fresh fruits and veggies, along with then supporting nutrition education and connections to local resources. So it's kind of a two-pronged program. On the one side, there's the vouchers themselves, which enable the purchasing of the produce, and on the other hand, there's nutrition education and counseling that goes along with it. Go ahead and move forward. Just a brief overview of the timeline of how our program came about and where it's at now. The program started in 2016, which is almost 10 years ago now, which is wild. As a pilot program directly with Peace Health, they had some community funds that helped make a 6-month pilot possible, a small cohort of like 21 participants. And then in 2017, we had our first year-long program, getting some federal funding, USDA funding for it. And we expanded our clinics we worked with to include CMAR in Concrete. And then in 2020, we were awarded a Gessnet-Finney grant to continue expanding the program. And by that point, we had gone up to about 175 we were at participants, and then their families. And in 2021, we had some extension funding through COVID relief funding, and really focused at that point on continuing outreach to our Latinx or Latina population, and increasing our partnership with CMAR through the Mount Vernon clinics. Okay, go ahead. Briefly, how our program works. The goal is to really be integrating this program into our partner clinics so that it becomes something that a provider thinks of when they have someone come to them, and someone who's experiencing a diet-related condition and who they also determine to be food insecure or low income. And so the idea is that this program comes to mind, and that a provider or some other sort of healthcare worker or other folks who are connected with clinics in the community would then refer patients to us, and patients can also on their own fill out an interest form through our online, through our webpage, and then we follow up with them and determine eligibility. And then from there, once a participant is enrolled, they attend a quarterly reunion in person. We're transitioning back to that. For a while in COVID, everything was remote. But we found really the personal connection and interface with participants is really valuable, and participants have had a lot of positive feedback about getting back in person. So we we've reinstated a quarterly reunion where folks are together and there's a nutrition topic for the quarter, and we usually do some sort of food demo and tasting. And then at that reunion, they also receive their bucks for the quarter. And then additional like goal setting and nutrition support takes place at the reunion, but also we ask providers to check in with their patients who are enrolled in FVRx a few times, as frequently as they're able, but a few times throughout the year to make sure that they're continuing a dialogue about how it's going for them. And then we have resources and opportunities that we provide as well to folks for wraparound support. Okay. Eligibility is based on income and health concerns. So a participant needs to be determined to be low income through a variety of methods. I won't go through all of them, and to be considered either at risk for or currently experiencing a diet-related condition such as like prediabetes, diabetes, high blood pressure, high cholesterol, other things. Okay. There are partners right now. So we have the Peace Health in Cedar Woolley, our CMAR clinics, and we also work with our WIC clinic here at United General. And you can go to the next slide. Retail partners. So this is an aspect of the program that we have really worked to continue to develop based on participant feedback over the years. And so we try to hit a wide range of types of retailers that we work with on like brick and mortar or, you know, storefronts. We work with a variety of different types of stores, from our co-op to the grocery outlet to like our Red Apple and some of our other smaller local stores. And then you can go to the next slide. I think I have other retailers on there. And then we also work with our local farmers markets here in Skagit Valley, as well as a few farm stands and 2 different CSA programs. And this has been, it's like challenging on the one hand to integrate a lot of different types of retailers because the paper voucher system, you know, requires different sorts of support in a farmer's market or in a farm stand, especially than it does at a storefront. But it's been really valuable from our perspective and participants' perspective to have a lot of agency in where they're redeeming their vouchers and in the food choices they're making. And I think when we talk about and think about food insecurity and ways that we're trying to approach and address food insecurity, agency is a really important aspect to, you know, keep in the forefront of our minds. And so it feels like a really valuable piece of the program that we've been developing. And, you know, for some of our partners, the vouchers have actually become a meaningful income stream. And so that feels like we want it to feel like a neutral relationship too. Okay, you can go to the next slide. Yeah, outcomes and opportunities. Go ahead. Yep. So I didn't change that to 2024 numbers, but I was supposed to say 2024. Our program right now, just to go through, I think a few of the kind of high level impacts that we've seen the program have, and then I'll spend a minute or two just kind of looking towards the future of like what changes we still hope to see and areas of growth we hope to see in the program. We have 80 enrolled participants at this point, and 50 of those, his primary language is Spanish or Spanish in the home. And there's the distribution of clients between our clinics. I don't think I need to go deep into that, but it fluxes from year to year, just depending on provider engagement and our relationship with CMAR that has really had an uptick over the years, and the folks that are participating through that clinic, because there's a lot of community members with high levels of need that are going to CMAR. And our redemption rate, I think it's just great to see that we've had a high level redemption rate over the years, which I think speaks to the value of the program to people who are engaging with it. You can go to the next slide. Hopefully this is big enough for folks to read, but just a few numbers, I guess. These are data points from our 2022 program, I believe, and we saw that participants who were in FVRx saw a 40% increase in the amount of fresh fruits and vegetables that they were eating in a day during the course of the program, which is a big increase. And then 78% of participants reported making progress on the health goals that they set, which one of the kind of tenets of the program for us is setting goals at the beginning, sitting down with participants and having them set goals. And so seeing a large majority of those folks get to reflect and note that they made progress towards our health goals is really rewarding. You can move forward. So I think the three main ways that we see benefits are, one of those is holistic health changes. So just the fact that this program supports, yes, direct increase in consumption of fruits and veggies, but also healthy lifestyle changes in general, and like just different ways of thinking about food and how food integrates into a person's well-being when they have the chance to participate in this program is one way. And overall life satisfaction is an area that we see people report increases in the duration of the program. Go ahead to the next slide. Finances and the local economy is another area that we see impacts from this program. Getting the vouchers, getting funds back into the hands of our local agricultural economy is a great thing. And then, like I mentioned, it places the financial decision-making power in the hands of participants. And of course, yes, reducing financial barriers to healthy food. And let's go to the next slide. And finally, family and community connections. So another goal is the way we have structured the program over the years is really making sure participants are getting connected to other community resources and ideally to each other as well, so that they're able to share experiences and be the teachers to others who are in similar positions, like really share how they have addressed the situations and the challenges that they face in regards to food insecurity and their own health. You can go to the last slide. Okay, just last minute or so. Areas we're hoping to grow and shift this program moving forward. Financial sustainability, whether or not that's on here, that's a big one for us right now. Really trying to continue to find ways to fund this program. It's an expensive one per participant. It requires a lot of funding, and so we're always looking for new ways to fund the program. Integration of these sorts of programs as a billable service would be amazing in healthcare settings. And I think that's a big goal at the state and national level too, is to continue to recognize the impact of these programs and secure funding for them. And moving to an electronic, as Lauren and Felicidad were talking about, like moving to an electronic type of voucher system is a huge goal for us. It's really challenging on a small level and with the diversity of retailers, but there's more and more, there's a really big push for it now from a lot of different programs. And so we're hopeful to be able to move towards a card-based system for all the reasons that they were talking about. And then really continuing to increase our focus on how we are supporting underrepresented communities in our region and making sure that the foods and the materials are, culturally relevant and supportive of folks. And then continuing to expand the clinics that we work with and the communities we serve. So I think that is plenty. I'll wrap up, and thank you so much for your time.
Thank you so much. I'm going to invite all of our panelists, all of our speakers to come forward for a panel discussion. Again, if you have any questions for our speakers, please either place them into chat or raise your hand and we can call on you to directly ask those questions to our speakers. But as we get started, I just wanted to start the question on thinking more on the topic of health equity. How are efforts being made to ensure that food insecurity initiatives are reaching those communities most impacted by food insecurity? We're seeing those populations, maybe minority populations, immigrant populations, or more rural populations. I'm just curious, what outreach strategies have you found to be effective, and how are we centering their culture within these initiatives as well?
I guess I can start. This is Bryce from the Community Services Division. So we have a network of approximately 600 providers out in the communities where we're actively recruiting at all times. So if anybody would like to get involved in this, they would be, we'd love to have you on board. But helping people apply for food benefits, as well as some of our other programs with cash and childcare and all the other things. But we're trying to get out in the communities so that we can, and that network of navigators that helps people apply for systems, because we know that sometimes applications for food programs in our area are a little bit complex to navigate, and people don't want to make a mistake. So if you can go into a food pantry or something, get a little bit of help as you do that, it's really makes people more confident in the system to have somebody walk them through it. So we do have a network of folks that are out in the communities that help do that.
And I can share from the DOH perspective with our fruit and veggie incentive program. I will say that it looks differently depending on what program we're talking about. So whether that's our prescription program with our healthcare partners versus our SNAP incentives. So with our prescription programs, when we opened up our applications in 2023, when we reviewed those, we actually reviewed all those applications really with an equity lens, and then gave priority to folks that were serving populations that were rural or maybe they were tribal health centers, FQHCs. And so really looked to make sure that we were able to zero in as much as possible to serve populations with the highest need across the state. That being said, we were only able to fund 12% of our fruit and veggie prescription applications. So we're not even making a dent in the need, but we're really trying to make sure that our available funds are going to those most in need. Then in terms of our SNAP match programs, I will say that we're falling short, especially around the accessibility to culturally appropriate food specifically. And we're in the midst right now of really doing a deep dive of why do we not have more culturally specific retailers participating? What are the barriers? We have had a couple in the past who've kind of fallen off the program, and we're trying to understand basically barriers and facilitators to participation. So we're hitting the mark in some places and have also a lot of room for improvement and are trying to work on that. So that's the DOH perspective.
I can chime in on some of the investments that the Department of Agriculture is making through food pantries, food banks, and meal programs related to addressing health equity and addressing disparities in hunger across our state. One of the first things that folks probably already know, but at this time it is still not legal for any of us, regardless of the kind of messaging, even from the federal government or from Governor Inslee's office. It's not legal for us to make determinations for funding on the basis of race, gender, ethnicity, or any other demographic factor unless there's an exhaustive disparity study that's conducted. And communities who are experiencing those disparities are pretty sickened by government investing a bunch of time and money and proving that their experience of disparity is real to be able to authorize the investment. That's the kind of framework that we are stuck in, bound by the current law, which does not allow us to make an investment on the basis of race. However, in 2020 into 2021, we worked with the Washington State University and University of Washington and had 2 reports completed. One assessing food insecurity through an equity lens that was conducted by a BIPOC group of food system leaders in partnership with the WSU Food Systems team, as well as the State of the Food Systems assessment from University of Washington researchers. Both of those documents combined, paired with a bunch of research that they did during COVID, as everyone was trying to understand impact on supply chain, were sufficient evidence to prove that Indigenous people are the most food insecure in Washington. People are also food insecure, and LGBTQIA+ communities are more food insecure than others. And as such, we were able to include those as priority populations for organizations that applied for grants. So we had this kind of opportunity to make investments to organizations, not on the basis of the people who worked at the food bank or their board composition, but who would receive the benefits. And then further, with the competitive grant opportunities that have been new for our agency to issue during COVID and since COVID, it gives us the opportunity to use the environmental health disparities map that Department of Health hosts as part of the HEAL Act implementation. It allows us to use that as an indicator for scoring, and community organizations that are working to serve areas that have higher environmental health disparities, including hunger and poverty, get more points in that ranking process. So those are some of the ways. And then we have a lot of mechanisms within our programs that really encourage kind of client-directed purchasing and kind of ongoing assessment, or like, what are the culturally relevant foods? What are the dignity foods? We've never had the opportunity to provide more support for halal meats before. But we have had, with more resources, we've been able to create more flexibility and more customization led by communities talking to people that they're serving.
Thank you. I was seeing there was a question in chat, and Lauren, I believe you started answering it. I wanted to see if you wanted to come off of mute, and others wanted to add to this too. Is they're highlighting how perishability of fruits and veggies, as compared to many other types, plays a role in the lack of fruit and veggie consumption as well. Is there anything that we can work towards to tackle this issue regarding fruit and veggies being quickly perishable, and how that impacts food insecurity?
Yeah, and I started to answer this in the chat. I really appreciate that question, because I think that's a very real issue. And then especially when you start talking about, there are some households who not only do they not have refrigeration, they may not even have a kitchen in which to prepare foods. And so that's why within our programming, we really work to try to be sure that we're also including canned and frozen items to make this as accessible as possible, and make sure that perishability doesn't have to be a barrier. I also know that on the federal level, with a lot of this funding comes from, Adele mentioned GusNIP, a lot of this funding comes from the Gus Schumacher Nutrition Incentive Program for our work and for Adele's work. And I know that they're constantly looking at how to expand the list of eligible fruits and vegetables. I believe on their latest RFP, they were talking about also including dried and some other items. So yes, Seth, I think that's definitely on folks' radar. Also acknowledging that farmers markets primarily carry fresh, but that's why we try to give folks the option of where to shop and what they can purchase.
Yeah, and I think that's been the funding streams, though it can be a challenge too sometimes, I think, for these programs. When we were first at least applying for funding at a federal level, there was a really strong, if not requirement, like a very strong push for fresh only. And so I think that's something that we need to continue to grapple with, and it's great that they're like continuing to expand, at a federal level, the sorts of things that can be included on these programs, in recognition of the challenges that a lot of people had and have with refrigeration and things. And I think the other thing which is possible with a smaller program, like our program doesn't serve nearly as many participants as any of these other programs do, and in some ways that's not a shortcoming, but it's a difference for sure. But then what we are able to do is provide some nutrition education components. So integrating like food preservation techniques, and making sure that when we're sharing out educational resources, we're doing our best to share like really approachable, easy ways to preserve, like prolong the life of produce items and then preserve them for people who have that capability, and where we're able to walking folks through like live examples of how that looks, so that it reducing barriers to it. But yeah, great question.
Yeah, Adele, I want to continue kind of on what you're highlighting here. Is something that you also discussed in your presentation was you also provide nutrition education along with these resources. It's not, providing access is so key, and we highlighted here today many opportunities to provide that access piece, but you also highlighted the importance of education with what is nutrition foods, like how, like what should people be eating depending on their diet. I'm curious if others too have an opinion on or have examples. How can we provide more education with the intervention? Do you see that as being a role within your organizations, or is that something the healthcare system, either the clinicians, the pharmacists, nutritionists, people on the call today, health plans could also support?
Yeah, I think it's huge, something that we've seen, like when we first started the pilot program and the first few years of it, it was always individuals from my organization, like meeting directly with participants. And that's a huge staffing time, take, but we really got to learn at an individual level what people's current knowledge was and where their needs were and where their interest was as far as nutrition and growth in those areas. And then of course in COVID, we had to go fully remote. And so we were left with asking, of course, our clinic partners to check in with individuals as they were able, and then sending things home in the mail. And that was great, but we're really happy to be able to be back in person again because, when we have times where we're working with folks on like cooking skills, I mean, you have somebody who's really comfortable and then you have someone who's never cut an onion before or a pepper before and isn't sure how to approach. And so, we want to send people home with all these fruits and veggies, but then if they're not comfortable slicing it up, how much of it, like we go back to perishability and things, how much of it ends up in the garbage is unknown. So I think yes, we are uniquely positioned as a 501c3 organization to be able to provide some of that nutrition education. At the same time, like there are so many ways that is integrated already into healthcare settings, or that could be paired with these sort of programs and integrated in healthcare settings, like our diabetes prevention programs, the DPP programs that exist. I know they do a lot of that sort of work. I think a huge challenge, and others in the healthcare world could speak to this better, that crops up is like the time restriction that so many providers feel when they're meeting with their patients, as far as like how much time do they really have to sit down and go through nutrition education. But I think it'd be amazing if that continues to be something that's prioritized to pair along with these programs.
Ask one more question for you all. Let's look more about sustainability of this work. Food insecurity is growing within our state and within our nation. So as food insecurity continues to rise, how can we work to sustain our efforts to ensure ongoing support for the affected Washingtonians? And what specific role do you think the healthcare sector can play in supporting this vision that you have?
Did I mention Farm Bill? I will offer that again. Like that nutrition title is a really big deal for your patients and for all of our programs. So organizing around that, absolutely. And then there's some comments. I know Bonnie had a question, but exploration of the 1115 Medicaid transformation waiver is also an interesting prospect. But local partnerships and organized advocacy are definitely things that we would hope for.
Ditto.
Same here.
And I'll ask one last question of the group. What is the most valuable takeaway you hope an attendee will leave after today's event?
There are resources available, and we at the Community Services Division are able to help access the SNAP program for some and the FAP program for others. Valuable, and you aren't alone. There are many people in this boat, and you don't need to suffer with any stigma. Experiencing poverty is not something that you need to bear alone, we can help.
I'll offer one that as healthcare providers, and I see the span of organizations represented, you're very familiar with the healthcare safety net. I would encourage you to start thinking about it as the food safety net, as a parallel for your patients, and recognizing that all of the programs that we've talked about today, they're all providing, you know, a portion of a household's healthy food needs, but anyone needs access to every single program they qualify for of this list of safety net programs. And like the healthcare safety net, we've got some disjointed parts in our food system safety net, but we do have a pretty robust coverage, and it all is tied together.
I think, yeah, just to build on what Katie was saying, is I think my takeaway is, one, yes, understand that food safety net, and that you can have a direct impact on your patients by really having an understanding and a grasp of this safety net, because it is a little bit difficult to navigate. And so if you're a community health worker, or you know, someone else who is screening for food insecurity, if you have a better grasp of these programs, you might be able to directly, rather than have your patients sort through what might be a good match for them, you might be able to tell them right away what might be a good match and provide those resources. So yeah, I think my takeaway is that I want you to walk away with is, you can get familiar and have a good understanding of these programs. And maybe we just need to write up a quick one-pager overview for everyone, so they can, you know, quickly at a glance look at that.
Well, thank you. We'll now continue to the next portion of our webinar today. We were going to break out into small groups to kind of have a facilitated conversation amongst the peers on the call today, and our panelists have the opportunity to join those conversations as well. And so we will break into small groups and learn more about what's going on within our areas in the state and where we're working from today. And then we will go ahead and come back and kind of share some lessons learned and talk about some of those key barriers we're seeing. And then we'll wrap up today's event. So I'm going to open all those rooms. You should be prompted to join a room. If you're having a hard time with that, please let us know, and we will assist you in that. If you don't have a facilitator in the room right away, that's probably because it's my room, and I'm going to be assisting some people getting into that space, and I will be there shortly. Recording, but there are so many different barriers that our patients, clients, Washingtonians are experiencing, and I think we highlighted some interventions today that can be used to support individuals who are experiencing food insecurity, but we also want to recognize there's still so much work to be done and continue to be done. I'm going to go ahead and share my screen for a moment. Thank you. You can all see that. In closing today, we want to thank everybody for joining us today. There is going to be 2 post surveys. One of the post webinar survey we will ask you to complete. When you're done completing that, there will be a hyperlink that'll say click here to access the CME claim form. If you are wanting the CPE education form, please follow the link for that. That is a SurveyMonkey link that can allow you to claim your credit there. We have a lot of upcoming events. I know there was some information in the chat where people were talking about ACHs and HCA and the 1115 waiver. We are actually going to have ACHs and the HCA coming to speak in August on the 1115 waiver updates and how it relates to community hubs. We have another learning lab, though, that's just before that, that's focusing more on the pre-diabetes care pathway and community support in the diabetes prevention programs, and how we can support individuals in preventing diabetes, and finding and supporting those that are at higher risk for developing diabetes. The August 13th one is that one that I just spoke about on the 1115 waiver and community hubs. There is to be updates to the 1115 waiver coming this July. So in August, we will be talking about what those are and how they impact community hubs and our healthcare system, as there is a special focus on health-related social needs. We also just wanted to highlight the Bree Collaborative sister program. The Washington Patient Safety Coalition is hosting a conference come October. It is a virtual conference, and that is October 15th through the 16th. So if you or anyone in your organization would like to join us, please sign up. Please share these events. But we really just want to take a moment and thank everyone again for coming today, for providing your time with us. We hope you enjoyed your experience here. And thank you so much for our speakers for sharing their knowledge, time, and expertise. And thank you to WISMA and the Washington State Pharmacy Association for providing those continuing education credits. This webinar has been recorded. I will send out the recording and the links to those post surveys where you can work to claim those CE credits later this week, or if not next week. Thank you so much, and we hope to see you all at an upcoming event.